Welcome to the webinar.
Welcome, and thank you for joining us today for the modification guidelines for the creation of a COVID-19 infectious disease unit in an existing long-term care facility. It's a special edition SAGE webinar, and it's shared in response to the continuing COVID-19 pandemic. Before we get started with the slides, if everyone can, as we get used to these Zoom presentations these days, click on the video feed on this Zoom, and if you could minimize it to show just the current speaker, so it's just one person at a time, but more importantly, scoot the presentation of the video up to the top right of the screen, and that way you can see the full slides with no interruption of information of the guidelines as we go on. So at this time, I'd like to introduce my fellow presenters here. Bob, let's start with you. This is Bob Dehler. And he's a professional engineer with over 22 years of engineering experience, including over 10 years at the Minnesota Department of Health. And let's see, Bob, let me read a little bit more about you.
Jill, would you advance the slide, please?
Oh, sure, absolutely. I forgot to do that. There. As the manager of the engineering services section, Bob, you are responsible for the plan review and inspections of construction in healthcare facilities throughout the state of Minnesota. And this section enforces the licensure requirements of the state of Minnesota and federal certification requirements of the Centers for Medicare and Medicaid Services, or otherwise known as CMS. Anything else you'd like to share, Bob?
Well, I would like to say, I guess, that we've got about 385 licensed nursing homes in the state of Minnesota and probably about another 175 licensed hospitals. And I feel like I've spoken with them all about this subject that we're talking about today.
Of course, it's important. Our next presenter is Scott Thomas, and Scott is a licensed professional engineer in Minnesota and 31 other states, and you're currently involved with skilled care senior living projects in the design or construction phases, located in Minnesota, Wisconsin, Iowa, North Dakota, and Nebraska. That's just right now. You've been with Kane Thomas Associates since 1991. Is there anything else you would like to share, Scott?
Well, basically, senior care facilities are one of our primary focuses of our practice. And right now we have 9 facilities in design and construction. So we're continually focusing on these types of facilities.
Perfect. I'm Jill Schroeder. I'm with Pope Architects, and Pope has a lot of experience in working in skilled care facilities. And in fact, over the last 15 years, we've designed over 2,000 beds of skilled care beds alone. That's not including assisted living, acute care, and specialty care, or outpatient facilities even. And I've been working in senior housing or specialty housing for over 25 years. I love it. I'm passionate about it. And not only have I been working in as a senior interior designer, but also as a senior planner. In addition, Bob, we didn't even mention this, but you and I are on the FGI revision team for the Facility Guidelines Institute, revising the regulations and the guidelines nationwide for our industry, which is very exciting. Okay, so for those of you that are not familiar with SAGE, we are the Society for the Advancement of Gerontological Environments, a membership-based organization representing and promoting collaboration between all disciplines in the senior living industry. SAGE is pleased to present AIA-approved webinars every month, and these webinars are free to SAGE members. Please visit us at sagefederation.org. And you can learn more about SAGE membership and the webinars that we're viewing. The annual membership is $95, but along with the webinars that we provide for educational purposes, there's networking events, social events, all kinds of benefits for being a part of SAGE. You'll be muted throughout the entire webinar session, and you'll have the option to type in any questions by clicking on the Q&A button at the top of your screen. We will answer those at the conclusion of the session if time allows. And we hope to be able to answer quite a few questions that have come up on this subject. But please keep your questions relevant to the topic that is being discussed. SAGE is an AIA approved provider, and participants in this course are eligible for one AIA Health, Safety, and Welfare Learning Unit. Please note that you must be registered for and logged into the webinar to receive AIA credit or a certificate of completion. SAGE will report credits earned by course attendees to AIA CES and will provide certificates of completion within 1 week if requested. If you did not enter your member number or request a certificate of completion upon registration, please simply just email us at sagefederation.org and we'll be glad to send you that. All right, so here's the course description. Essentially, we've brought this as a special edition webinar because of the urgency of this COVID-19 crisis. And a lot of skilled care facilities are getting bad press and needing to address this issue immediately with residents who are affected by the COVID-19 virus and how to create a safe environment within their facility while all the while keeping all of the rest of the residents healthy and safe, and to calm fears by both family and residents living in their facility. So this session, we're going to walk through what the state of Minnesota has put together so far for guidelines in creating this new infectious disease unit. These guidelines are in process. Each day they change, right, Bob? I mean, it's an evolution. It is. It's a dynamic change that we're adding to each day almost, or revising these guidelines. The guidelines that we're going through today are regarding or relevant to the building structure, the walls. Well, let's go to the next slide here. Bob, why don't you walk us through the learning objectives?
Yeah, so today we're going to talk about, well, what we usually get questions about. So Scott and I are getting a lot of questions about converting individual bedrooms into temporary airborne isolation rooms, also converting wings into temporary isolation rooms. So we're going to talk about what we've seen and what's worked, and some of the other thoughts that we get from that. Scott's really going to talk a lot about the mechanical systems and how to create these negative pressure environments in these units and rooms. We're also going to get into some risk assessments. You'll see I'm gonna wear out the word risk assessment, so I'm gonna warn you right now. We talk a lot about risk assessments because really this is all facility dependent. Each facility will have their own risk assessment and their own mitigation. So just because we say you can or can't do something today, it all depends on what your specific facility is going to do in your mitigation. Right. And then the last thing we'll talk about is creating a wall to make a temporary unit. A lot of times we want to have, use existing walls and doors, but many times that doesn't work out as well. And so there are walls that are built to create those units. And we'll dive into that a little bit and talk about some of the pitfalls and some of the things to think about when you're doing that. So first off, I guess what I'll say is that everything I'm telling you today is for the state of Minnesota. It's what we've done. To be honest with you, when all this started, I tried to go to other states and to figure out what they've done so I could, borrow what they've done. And I had a hard time finding some documentation. So after we had a few conversations with facilities, we documented those conversations and documented some of the things we talked about. And really that's what we're going to be talking about today. So please, if you are from another state other than Minnesota, find the Bob in your state and make sure you're in communication with that person. But not only that too, there are so many authorities having jurisdiction that you have to work with. Remember to include them all, in the health department, but in particular, your fire marshal. Sometimes it's a state, sometimes it's local. There's building code officials. Sometimes you have to bring your insurance in when you start talking life safety code and other requirements. You just want to make sure you have all the right people, you're communicating with all the right people. And again, we're going to be talking a lot about risk assessments. What we're talking about today is all individual. So you need to really assemble a really strong team to go through these risk assessments. The teams would include your infection preventionist, your facilities personnel, clinical, the nurses, leadership, and for sure your engineers. As we go further today, you'll hear we'll be talking a lot about the mechanical systems, but you also want to start pulling in your electrical engineers when you do things different than what we're talking about today. Because today we're talking about converting rooms, individual bedrooms to negative pressure, and also individual units to negative pressure and those walls.
Bob, I think I want to add too, because you keep mentioning this, as we go through and start going through these guidelines that you've created, let me zip to that. I want to tell everyone, you can write notes, but if you're registered for this, which you certainly are if you're viewing it right now, you're going to get a physical copy of each of these slides. Not only of that, but we're recording this webinar, so you'll get a copy of the recording as well. So we want you to listen and react, write questions that are relevant, but no need to write down every single bullet point that we're going through as Bob explains it.
And since we are recording this live, please don't hold anything I say against me.
All right, let's get started.
Okay, so basically, based on your infection control risk assessment, when we're talking about converting a room, I guess what you would do is you will take the window out, you would install a window adapter. We'll talk about that in a little bit. Set up the HEPA machine and the flex duct. You also want to seal all the return grills and turn the HEPA machine on and adjust it to obtain your proper pressure. Well, that sounded really easy. Now we're going to go into a little bit of depth. First off, when you're looking at the infection control risk assessment, when you look at these rooms, you want to make sure that the bedroom's walls go up to deck. If the bedroom walls end at the drop ceiling, you almost want to think about another room, because these rooms in these infection control or in these negative pressure rooms, they need to be sealed up pretty tight so you can get your air changes and maintain your negative pressure. And I'll tell you that we based these checklists or these guidelines on ASHRAE 170. If anybody is familiar with ASHRAE 170, they're ventilation requirements for healthcare. And we based them off that, and we based them off the airborne infection isolation room. Because really there's no such thing as a negative pressure bedroom. So what we've done is we've taken what we've known and kind of adopted it or adapted it to this COVID-19. So the other thing that we recommend you doing is to tape off the returns. If you have one bedroom and there's return air that's getting distributed to the rest of the building, it's probably a bad idea. There's also a document out there too that will recommend that you can recirculate that HEPA air. So it goes through the HEPA machine and you stick it on the return grill, and then it basically just shoves it back into the HVAC system. We recommend not doing that, even though it is in some documents and technically allowed. First off, it could give you a little bit of heartache in your system if you're shoving 500 plus CFM of air through your return, but also it'll kick up dust and dirt. It just might cause more problems than you need. So so first off, what you want to do is you want to take out the window to the bedroom and put in a panel and make sure you get a nice tight fit. But you want to make sure the panel that you put in is not plywood. Everybody wants to use plywood, but not plywood. First off, if your state fire marshal or your local fire marshal sees plywood in the room, they will probably get a little bit excited. So combustibility wise, it's not the best idea. And then also cleanability. Your infection preventionists will say plywood is not a good idea. So don't use plywood. If you're looking for something, you can talk with your glass supplier. They generally have panels that are, that are made of metal, little sandwich panels that you could use.
Okay.
So connect your HEPA machine to your exhaust fan and make sure you locate the exhaust in accordance with your risk assessment for the best airflow. We also recommend that you plug in your HEPA machine to emergency power. So if the power does go out, if you know, doggone it, you have something else bad happen and your power goes out, you really need that, having that pressure maintained in that room is super important. We also recommend that you maintain the pressure in the room to at least 0.01 inches water gauge in relation to the air pressure in the corridor. Again, we pulled this from the AII room requirement. It's not very much, but it's very, very important to maintain that negative pressure. And you want to monitor those air pressures periodically to make sure that you're maintaining that air pressure. You can do this with you know, audible electric or manometers, smoke tubes. You can do a lot of different things, but you want to make sure that you're doing that in accordance with your facility plan or your emergency plan. Sometimes people want to know how many times they have to do it. It's like, well, what does your emergency plan say? Does it say you have to do it every day before people go in and out? So just make sure you stick with your plan on the time frame. We also say consider maximizing the exhaust fan in the toilet room. You know, if you can get a few more CFM out of the toilet room, you know, you see if you got some variable drives on there where you can turn that up. And if your exhaust is not dedicated, you should, as part of your risk assessments, you should look to see if you need to do anything else. We've had a number of facilities decide that they wanted to put like a MERV 14 filter. I'm not even sure how exactly they attached it, but I had a feeling they were just somehow attaching it to the ceiling in the toilet room. But they wanted to have that extra level of protection. So if your infection preventionist in your facility says, you know, I don't know if I want this air being exhausted, because you never know what'll happen with the system if it goes directly out, or maybe if something gets you know, short circuited, it could pull somewhere else. So a lot of facilities that we've talked with have been putting some sort of MERV 14 or better at the exhaust. Now you got the HEPA machine and you have it sitting in the room and you have the exhaust going out the window. You want to make sure that that exhaust terminal in that window is at least 10 feet away from anything, from air intakes, operable windows, sidewalks, patios, anything that's accessible to anybody. You don't want, even though it is filtered through the HEPA machine, you want to be careful and have that clear at least 10 feet. The door to the room, again, it's super important that these rooms stay, you know, under negative pressure. So maintaining that pressure is very important. So keeping that door closed is one of the main ways that you do that. So we would say consider installing a closer. Many facilities aren't doing that right now, but they do have it very, they do have it spelled out in their policies and procedures that the door is always closed at all times, so that pressure is maintained. And if you don't have a pressure monitoring device, we're recommending that you install something. You know, whether it's a smoke test, air strips, or an actual electronic manometer that'll monitor it constantly. Another discussion that we've had with many facilities is about removing privacy curtains or fabric drapes. Now, privacy is always important, so be careful. Make sure you review this with the multidisciplinary team. But sometimes we're seeing people replacing the privacy curtains with something else. But the idea is, if you've got a 2-bedroom and you've got a HEPA machine that's exhausting to the outside, you want to make sure that the airflows aren't disrupted a whole lot. Also, when you're talking, you know, fabric drapes, they tend to, you know, that they'll have to be cleaned and disinfected. So you want to make sure that, you know, if you do have any of those things, that they are part of that disinfection and cleaning process. So a lot of people are thinking about taking at least the drapes off and thinking about their curtains. when you have the HEPA machine, this seems kind of like a no-brainer, but it's always a discussion that we're having. But when you have that HEPA machine and the exhaust that goes out the window, you want to make sure that's located out of the way. You want to make sure that you have clearance for egress and nurse access to the patient or resident. So make sure you locate that HEPA machine out of the way. And last but not least, for the conversion of a bedroom, if you have an anteroom, some places are thinking about putting in anterooms. There are many ways you can do this. This is why you hire a really smart engineer like Scott to help you out with this stuff. But if you do want to have an anteroom, we would recommend that the anteroom would be negative to the corridor, but the patient room would be negative to the anteroom. So the most negative would be the patient room. The next negative would be the anteroom, and then you would have the corridor. So the next question we always get is, okay, well, once we get, 3 rooms like that, it might just be easier to convert a wing or a unit into COVID. And once you start installing all these HEPA machines, if you can find them now, it might be easier to consider a wing. So if you are considering a wing, again, make sure you're running your infection control risk assessment, make sure you're doing all the other risk assessments that are necessary. And really the same ideas that we discussed on the single rooms, the individual rooms, you'd want to use for the unit. So again, 12 air changes an hour and maintaining a negative pressure of 0.01 inches water gauge. The most important thing with the air pressures is a lot of times people will talk with me about, well, we can't get 12 air changes, but what do we really have to do? Again, the 12 air changes and the pressure were recommendations pulled from ASHRAE 170 for airborne infection isolation rooms. So to me, the most important thing is that you're maintaining that negative pressure. If you can only get 10 air changes or 8 air changes, but you can maintain that negative pressure, to me, that's the most important thing. So if that's the case, then it would just show up on your risk assessments that yes, you may not be making the 12 air changes, but taking in consideration of what your infection preventionist says, and if people in your facility believe that you're okay with something that doesn't quite meet what we have for guidelines, to me, this is a facility decision and facility mitigation. So you should check all the walls around the whole unit. So in the bedroom, when we use the one bedroom, we checked all those walls to make sure they went up to deck. You're going to want to do the same thing for this whole unit. And having these walls go up to deck is really of utmost importance. Without that, you're going to have a really, I would almost say, an impossible time maintaining that negative pressure. So make sure the first thing you should do when you think about converting a wing or a unit is to make sure those walls go to deck. And you want to make sure you seal all those penetrations as well. In the unit, you want to locate your HEPA machines and exhausts in accordance with your risk assessments and your emergency plan. You want to be aware of how the air will flow in that unit, and you want to kind of make sure all the return vents are sealed as well. You want to think about where you want to put these HEPA machines. I've seen some facilities will just keep them at the end of their quote unquote corridor at the end of the unit and exhaust them out there. Sometimes they'll use a few rooms at the end that they'll have them in, but basically they're putting a negative pressure in the entire unit. So again, make sure that goes through your risk assessments and you kind of really understand how that air flows.
I should add here, Bob, that we did not state at the beginning, and we should have, but COVID-19 has not yet, they're still learning a lot about this virus, we know, but we're treating these guidelines as if it's just all a blanket guideline for an infectious airborne disease unit. So
Yes.
We know that right now, as of today, that COVID-19 is not identified as an airborne infectious disease, but we're treating it as if it were because we don't know enough about it.
Yes, the CDC does not recommend having the negative pressure like we are today, but people have also got COVID-19, 15 to 20 feet away from other folks. So there's people on both sides of the aisle. We're taking the more conservative route.
Right.
All right. So with our mechanical systems, you start taking all this exhaust air out of the building. It means we're going to need to introduce more outside air into the building, which means more energy, greater heating and cooling capacities required potentially. If you have a negative building, if you don't address the more outside air being introduced through an air handling type system, this assumes you go with a wing, or if you have a bunch of numerous rooms, it could create a negative building pressure on your building, creating infiltration issues and potentially have condensation type issues in the envelope. So that's the biggest thing to look at. We did put a list together here for assessment considerations for MEP systems. This is for both the entire wing or just the individual rooms. So are you planning to go with, is this planning to be a temporary or permanent type of change or fix, if you would? And obviously it's probably very urgent to get this done. So maybe you start out with a temporary with a plan to develop a permanent resolution type of thing. So if these exhaust units, the HEPA units, with AII type rooms, if you're trying to use existing systems, it'll increase the static pressure of the systems due to the increased filtration static pressure drops. So that needs to be considered with entire type systems with a wing type application. So as Bob talked about, 12 air changes per hour is recommended for AII rooms. For an individual room, you're looking at, assuming 150 square foot with 9-foot ceilings, it comes out to 270 CFM, which isn't really that bad as far as a window unit. And I think the smallest units start out about 500 CFM that are real common. And we'll show a picture of a typical unit later on. So say you're doing a wing and you have a DOAS unit, a dedicated outside air system. It's either a heat wheel type unit or a plate and frame type system. With the heat wheel units, there is cross contamination, so you're going to need to divert that exhaust air in some way, shape, or form, possibly add an exhaust fan and separate it out. As Bob said, if you have a dedicated system, you can't just take 3 rooms and tie it into the bigger system. You need to kind of look at, okay, what does this unit serve? Okay, this wing, does it just serve the wing or does it serve more than the wing? If it serves more than the wing, you need to really look at that and separate that out. Plate and frame type heat exchangers, you should not have any issues with cross contamination, but check with the manufacturer, get test data, make sure you're not going to have issues down the road. Sorry. And then, so we're talking about the wings and Bob talked about removing a window. Well, okay, so you put a mobile air cleaner in, a MAC, in the room. Maybe it's easier to go out the wall. You can just take a round or a flex duct up through the wall, and if you have a stud wall construction, that's probably simpler and probably work easier, less costly and less impact overall. As talked about, what's your building balance? And how does that affect your heating capacity? Well, normally, the FGI guidelines and state of Minnesota code requires redundant heating capacity. So you're probably going to be okay with the heating aspects. So this type of situation, you need to tap into that spare boiler. Commonly we'll design systems with 3 boilers total with 1 standby unit. So you've got quite a bit of capacity there. Cooling, well, if it's a northern climate, it may not be that big of an issue. And the elderly really, you got to be careful, but it's not like you're going to be without cooling completely type thing. And obviously with cooling capacity, it's a lot more critical in your southern climates. Bob also mentioned emergency power capability. ASHRAE and FGI both recommend AII rooms to be on emergency power. So it's almost beyond a recommendation at that point. And then if you're doing a wing, your fire alarm, fire protection systems, look at that. Look at your lighting systems. Where does that wall fall? What kind of impacts is that going to have on those systems? And another architectural client called me about this, noticed I was on the list, and sent this over. This is a real good example project in New York City where they converted a hospital wing for COVID. You know, this is a little different with long-term care, but it's some good lessons to be learned there.
Yeah, it's similar. It's useful. And I guess it's all just about sharing of knowledge. So all information that can be shared is what we're all after. Is this
So
that
here's
unit, Scott?
What's that?
Is this that unit that you were
Yep,
just
the mobile air cleaner type unit. This is actually, it's not hard to see the scale. This is a 1000 CFM unit, but they do make a 500 CFM unit, which is the face area of the filter, which is on the opposite side. What you see on the left side there is the exhaust duct connection. You do a hard duct to it or flex connection. And for the 500 CFM unit, you're looking at a 2 foot by 2 foot on the intake air. And I think the unit's about 30 inches, 3 feet long right in there. And you've got the removable piece on the top there with some bolts to change for the filters. And you'll have a pre-filter and a final filter. Your pre-filter is a less expensive filter, and the final is your HEPA type filter, which you change the pre-filters more often. And then you can kind of get into this control thing too. You know, these fans are ECM motors, so it's real easy to vary the speed. So if you want to get sophisticated with the controls and automatically control the unit, it makes a lot of sense. So, you know, like Bob said, the minimum is 0.01 inches of static, which is hardly anything. It's so typically you want to set it up when you do your setup. Let's say start it out at about 0.05 or 0.03 inches, and it gives you some flexibility for loading of the filter, because as that filter gets loaded, if you're not changing the speed on the fan, you're going to get less airflow, and then it's going to be less negative pressure. So it's just some general things to think about.
Let's talk about the temporary walls, Bob, that you had mentioned. There are a lot of questions that are evolving around these temporary walls too, and how that affects life safety code or exiting anything. So let's go through these.
Yeah, temporary walls. We've had a lot of discussions on these. And I'll just tell you too, when you start thinking about the temporary walls, you know, when you do your risk assessments, you know, really make sure you bring in, especially the state fire marshal or your local fire marshal and others that would be interested, because once you start talking about walls and blocking off egress or changing egress, you're really getting a lot of other people interested. So really, again, make sure this goes through your risk assessments and the interdisciplinary team. You want to make sure, one thing that we're always stating over and over again is that you want to comply with any mitigation requirements that are detailed in your emergency plan or your risk assessments. The first thing is we want everybody to look at this before they come talk to us, to make sure that, you know, their whole team is on board and think that's a good idea. Again, review your proposal with your local or state fire marshal, just so they understand what's going on and in case they've got some extra comments. Before we even go down this road, we really want to stress that you're probably better off trying to find an existing rated wall, like a smoke barrier wall, or using a smoke compartment as your unit. So you don't have to build a temporary wall, because as we know, those smoke barriers are, they should be 1 hour rated walls, and they should have all their penetrations filled. So they're going to be sealed a lot tighter than any regular wall. But if you can't use existing rated separations like smoke barriers, then that's when we're coming into these temporary walls. And what you want to think about first is where it's located. You'll have an idea where you want it to be located. But what you want to do is, once you have that idea, you want to look up. And you want to essentially locate this wall in between 2 sprinkler heads as much as possible.
Actually, let me jump ahead. You're on letter D here. You're talking fast, Bob, so
Yeah.
there we go.
So you want to make sure that, you know, it's in between two sprinkler heads, because if you're too close to one and further away from the other, you could have some coverage issues with your fire marshal. So the location of these temporary walls are really, really important. I would even review the location of the temporary wall with the fire marshal as well, just so you don't have any problems with those with the sprinkler system, even the smoke detectors, making sure that you're not messing with any of those systems.
That makes sense.
The hottest topic that we probably discuss is what these walls are constructed of. And we are strongly recommending using steel stud and drywall. The conversation that we have with most people are, you know, how come we can't use plastic? And the answer to that is plastic is a temporary solution. Plastic is generally used, you know, if you ask us in MDH engineering, we basically try to have you limit that to a day of activity. So if you're painting something, doing some drywall work, plastic is a great barrier when you have people working there all the time. But then at the end of the day, it comes down, or you know, after you're done with that work, it comes down. As a more permanent solution, even though these are temporary walls and everything's temporary, you know, we're probably looking, we don't know how long we're looking for this, but I've talked with a number of other facilities, and their infection preventionists usually have infection prevention policies, infection control policies that limit the plastic separations for about 3 days. The most I've ever heard is maybe 4 or 5. But that's because the plastic is not a good barrier. It does not stop people from doing anything.
Right. Temporary definitely means temporary, not only from that infection and the permanence sake, Bob, too, that you're talking about, but we also have talked about that fear. We're trying to calm fears. If you are a resident that has not been affected by COVID and you are pretty adjacent to this space that is now going to be called the COVID unit, you do not want to approach an area that's just sheeted off with plastic. Simply, it's not going to give you a sense of security and a state of mind that you're going to want to be in, right? I mean,
yes, that is correct.
let's go to the next one, Bob.
So when you build that wall, you want to make sure that it's sealed tightly to the walls, because you're going to make that unit behind it probably negative pressure. So you want to make sure that it's sealed pretty well tight to the walls, floors, and the ceiling. Now, the issue that you're going to have with these temporary walls is, well, you have to build the wall to the deck above or just to the drop ceiling. And that will be something that you really have to work through in your risk assessments, because you really should go to the deck above, because you want to maintain those pressures, and you got to maintain that seal. If you've got a drop ceiling on the other side, you're going to have a hard time maintaining those pressures and maintaining that seal. So you got to think really long and hard about where these walls are and how they're constructed. Door size. We had a facility come talk to us, and they had this plan. They want to put up this temporary wall. Everything sounded great, and they were putting in a 30-inch door because that's one they had in their basement. And we said, well, okay, you know, when you start looking at everything for you know, egress and life safety code, in these units, in the COVID units, generally, if there's an emergency, you're not moving them to the other side of the smoke barrier. You'll probably be rearranging your emergency procedures. So, you know, how are you moving people? Do you need a double egress door? And for the most part, it's not necessarily required. And so for this COVID-19 and for this temporary location, the state of Minnesota has approved having, you know, a single door in these temporary walls for that reason. But you want to make sure you size that door properly. The facility that we talked with that had the 30-inch door, they also found a 44-inch door later, and they ended up putting that in because they needed to move equipment in and out. They have to do all this other stuff. So, and that door, you should really have a closer on it, just so you've got that good separation of environments and you maintain that pressure, and it always stays closed. We also say you should consider installing a window in that door. The bigger the better. The door does not have to be rated, so you don't have to have special glass or anything like that. But we've found that facilities that are putting these windows in, they're able to communicate better, even though I think you could probably talk through a wall or a door. When there's that window, they can communicate better. So they're really, it's safer because if you have a window, you can see if you're opening the door on somebody. But the other thing is you can communicate. And if you can communicate with people rather than having to open the door and have people garb in their PPE, you could be saving on PPE. And again, your emergency procedures. I say, do you need to adjust your emergency procedures? Probably the answer is yes, we need to. And so you really need to figure out, in emergencies, where are you moving people? If you're thinking about having this unit on the second floor, how are you going to move people out of that second floor unit and not move them through the other part of the facility? So, you really might want to consider having it on the first floor. Maybe you've got enough room in your exit stairs that you can locate people in. But again, going through your risk assessments is where you're going to get all the answers to this. And again, we recommend creating the negative pressure in these areas. We've seen facilities put HEPA machines in the rooms, towards the back of the unit, so that air is flowing, through the unit out the back. We've seen them put in a couple machines and they have maybe a window at the end of the unit, and they put the machines and they exhaust out that window on the other end. Again, I think the most important thing to really be thinking about when you're going through your risk assessments is the most important that you maintain that negative pressure, and having the walls sealed and everything tight is probably the most important. Getting the 12 air changes will be based on your risk assessment and what you think. But the larger the unit that you get, the harder it is to get those air changes if you're just adding some HEPA machines. And again, in these separate units, if you do have air handlers that are serving just that unit, I have spoken with a few facilities that have been able to alter their system. They talk to their mechanical engineer, and they're able to adjust their current system to make that area negative pressure and maintain a negative pressure in that area with or without adding extra HEPA machines as well.
Perfect. This does conclude our AIA CES portion of the course, but we're not finished yet. We did want to reserve quite a bit of time to go through questions. And as we had said before, you can find that button to click on questions in the upper left-hand part of the screen and type out your question. We'll be happy to answer those questions. And also too, all three of us have agreed to stay past the hour if the questions exceed past the hour. If you're not able to stay with us beyond the hour, please write out all questions. We're trying to make it simple for you. Write out all questions and send them to me. There's my email address right there. And our intention is that after the conclusion of this webinar, as I said, it's being recorded. You'll get a copy of the slides, a copy of the recording, and we hope to give a copy of all questions asked and the responses to those questions so that you'll know what those answers are. If we have some recommendations provided by the state of Minnesota that you can bring to your own state, but we're trying to make it an easy procedure. And again, it's an evolving quest here. All right, let's go to questions.
So as you put your questions together, just, mechanical, electrical, fire suppression just needs to be considered, especially as you do a wing, like Bob talked about, with where the door is located, and aligning it with your smoke partitions right now is a really good idea. And check your building balance and your mechanical systems and what you need to do there.
I think that importance of the mechanical systems being the most important part of it all. Also, too, as we've addressed, we know that a lot of facilities are getting that bad reputation. We've already mentioned this. It's important at this time, as we build these guidelines and regulations, to hear a lot of feedback. You have my email address for questions, but please send me an email if there's any positive outcomes that you're finding as you create these units. Positive outcomes that we want to hear from, regardless if it's traditional care or if it's a household method. We're starting to think and get feedback from any facilities who have now built new communities using that household model so that it's small bed counts per unit, and they're getting better feedback or easier to control and manage this infectious airborne disease guideline built in their unit because it's smaller. Both the focus of the workers or the care providers in these households staying in one unit and only working in that unit and not coming out to work in other units. So we want to hear a lot of feedback, positive, so that we can use that as a tool and spread that information along to others. Let's jump into the questions. All right. The first one is, has a timeline been created to inform when the new revised FGI guidelines will be released with updates in response to the pandemic we are facing now? Bob, do we know an answer to that? We're just forming the team right now.
You know, I don't know.
We're forming the team right now. We'll get the answer
Yeah.
to that and respond back in an email. That's asked by Allison. So we'll respond back to that as for a date, and we'll have it open for public comments, I'm sure. And then we'll say the date that we expect to release the new FGI guidelines on that. Next question. I won't read that. Next one. Are negative pressure rooms required for COVID patients in the skilled nursing facilities? I thought the CDC just said closing the door is adequate if the patients are segregated.
That is true. That is what CDC says. We are erring on more of the side of being conservative, and with what we know and what we understand. And even in Minnesota, I was nervous to actually talk about this, recommending the negative pressure when it's not necessarily recommended by CDC. But as I talked with different facilities, nursing homes, hospitals, and long-term care, were considering using the negative pressure. And so I felt a little bit better, at least in Minnesota, they were all considering it. But it is not necessarily advised or required by the CDC.
Okay. All right, next question. Is SAGE or the Minnesota Department of Health recommending air or negative pressure rooms for COVID-19? I think you just addressed that.
Yes, we recommend. We recommend that you do the negative pressure. And again, I guess it would be based on your risk assessment. If your risk assessment says that you don't have to, and whatever you're doing, whatever other mitigation tactics you're using will work. It is up to the facility and their risk assessments and mitigation.
Bob, do you see the comment on here? Let's have a betting pool for how many times Bob uses the term risk assessment. I love it. Okay. You don't want to sound like a broken wheel, but it is important, and we're trying to drive that home. Do other systems like—
now I've driven people to gambling.
I know. Okay, do other systems like light fixtures need to be replaced with sealed and gasketed light fixtures as well? Scott, that might be a question for you.
Assuming it's kind of like Bob gets back to the risk assessment thing, it's better from a cleanability standpoint, but if there's no airflow going through there, because there are return air light fixtures, but for a skilled care facility, I would be very surprised if you had those. That's a good question to take a look at, and can the existing fixtures be cleaned, and are they safe?
Yeah, it's a very good question. Next one, will the recording and handouts from this webinar be provided? Yes, they will. We are recording it, and you will get a full copy of a PDF version of all slides used in here. as well as a copy of the questions. And I think we're going to attach a cut sheet of that HEPA unit as well, so that you'd have that at your fingertips. Another question, how do you balance adding closers to doors when seniors have a difficult time opening them? Are you assuming that they are not mobile at this time of care?
When residents are in, if they've got COVID-19 and they're in their rooms, and you've got, you know, one room set up, they're not leaving their room.
No.
If they've got a unit, then that whole unit, they'll be cohorting folks with COVID-19 so they can move around the unit. But when we're talking about putting closers on the doors, we would recommend at the beginning of a unit, so that door always stays shut. And those residents aren't necessarily, you know, allowed to be walking around the rest of the building. So the only time the closers are required is basically on the entrance door to the COVID unit or a COVID bedroom.
Let's talk about that too, not only from the closers, but also from the signage and identifying the unit. We talked about, or maybe, well, what we recommend. We're trying to evolve to what we recommend on how to identify those particular units, whether it's a single bedroom or the unit, on how to identify it as a COVID-19 unit. And what we're thinking is that it would not say the words COVID-19, of course, on the signage. And I'm not sure if there's a very good verbiage to use. If someone has some, please email it and I'll send it out to the whole, everyone attending. But you've got to think about it from the perspective of, yes, we want safety and we want to make staff and family visiting aware that this particular unit or bedroom is controlled. But we also don't want to enhance or amplify the amount of fear that already is in the family and the other residents living in the space too. If they see COVID-19 unit written on signage that's through this door, they're not going to want to come and be approached within 20 feet of that door. So we've got to be cautious on how you identify that door and unit as pertains to the whole community as a whole. Next question. What is the recommended frequency of changing filter media in a MAC system or other air scrubbers? Scott?
It all gets back to the loading of the filters themselves. So typically you put in a pressure sensor, differential sensor across the filter to identify when you need to change it. You know, your pre-filter, you know, and it varies so much. I'm thinking it'd be probably a month, and then those final filters would be twice a year. But it's one of those things you have to kind of work through. And I personally don't change filters, but that's generally what would be what you would think would be the correct answer.
Okay. Next question. Can you talk about what you see for design changes for long-term care going forward? I think I'll take that, and Scott and Bob, you chime in too, but what we've addressed here is just units themselves and bedrooms, units, and that temporary wall. What we haven't addressed is how this affects operationally from an operation standpoint is the soiled utility, soiled linen, the laundry, and bringing food in. What do you do with those dirty dishes and what that process is, and having every state identify what that potential process is, the best requirements or the best guidelines to follow on that procedure. So the design changes might affect those areas as well. And another thing is hearing the feedback, as I mentioned, on household models. We're thinking that a household model, a community or facility that's using a household model is probably working a lot better in the creation of these units, in that it's so small scale and it's based on the smaller unit or smaller count of residents per unit, or per household, I should say. So that's another reason why we want feedback. We want to hear back. Bob or Scott, any other design changes that you can foresee moving forward?
Well, one item I can think of is humidification. It's most facilities do have humidification, but we've come across a few projects lately where it's not mandatory. It's a recommended item in FGI, and And with humidification, that does help reduce the transmission of infectious diseases. I think it helps tamp down the particles more, so they're not airborne as long, if you would.
Yeah.
So that's one item. And the other item I mentioned too is, so you want to set up one of your neighborhoods for COVID or infectious wings, was definitely don't use heat wheel type energy recovery. Compromise that energy efficiency a little bit so you don't have to worry about that.
For the humidification, we have a number of projects that have opted for VE purposes in the early stages of planning to not take that humidification. Is there an easy way? Let's say there is a facility that opted not, and it's already been built. Is there an easy way to add humidification to their existing system?
Well, you could. Oh, well, it's easier if you plan for it from a design perspective, so you can add it later. Where you bring in say you put in electrical humidification or gas, you bring those services in, so it's more of a plug and play later. So it kind of depends on the configuration of the systems and what you're going to run into if you need to retrofit to add humidification.
All right, Bob, is there anything you'd want to add to this, or should I go to the next question?
No, we can go to the next question.
All right. Do the proposed modifications require the Minnesota Department of Health plan review and local building permits?
Ooh, good question. So in Minnesota, if you are doing something temporarily, construction-wise, to deal with the COVID-19, we are not requiring a formal plan submittal and a formal plan review and inspection. If it's temporary, we're asking that you talk to us, run us through your project and what you're thinking of doing, but it does not require a submittal, which includes, the plans, the form, and the fee, if you're doing something temporarily. Now, if you hire Scott and you start looking at something more permanent for a solution, which we have had a few, once we're talking permanent solutions, we are still doing those plan reviews and inspections. We are working with you, by the way. If you are doing something like that, we will work with you and make sure that there's no delay in our review, and we're putting a high priority on those reviews. So if it's a permanent solution for this problem that we're dealing with now, then yes, we would. If it's a temporary solution and you're going with all of our guidelines, then we wouldn't have to do anything formal. But
Okay.
we are encouraging people to call and talk to us if they want to do something, and we can help them out.
Okay. For next question is for a negative pressure room. If the walls don't go to underside of deck, what are the drawbacks or concerns about replacing a ceiling with a gasketed system?
That's a possibility. There would be some time and money involved as a facility to do something like that. I'm guessing you might replace other items too in the ceiling. If you go to gasketed, would you replace the light fixtures and other items in there? But that is something you can do, and I guess that would come through your risk assessment and what is determined that you need to do to maintain those pressures. Without something on, without having a gasketed ceiling or, putting a hard ceiling in or something along those lines. And if you don't have those walls that go to deck, it's gonna almost be halfway impossible, or if not impossible, to maintain a negative pressure with all that.
Okay, as I'm going through the list of the remaining questions, it is 1 minute to the top of the hour. And I want to remind people, if people need to jump off here, you're going to get a copy of this presentation if you're registered for this. You're going to get an email summary. So please write in your other questions and we'll address them later. And as you exit this webinar, you're going to be prompted for a survey, and please fill it out and give us all kinds of feedback on, was this an appropriate subject? Would you like to have more webinars on this subject brought forward to you, and then what time frame? We want to hear any and all feedback too. Not only that, there's another webinar that we're broadcasting tomorrow on a different subject, but please check our website to get more information. Let's continue with the questions in the event of time, but we're going to stay after the hour. Okay. Facility is taking one floor of a wing and converted it to a COVID-19 wing. If the recommendations you've made are met, will it be safe on floors above and below the COVID floor? So they're probably talking about second floor. They created a wing on second floor. Is the first floor safe and is the third floor safe, in your opinion?
Well, that's a great question for an infection preventionist. I would say if they maintained a negative pressure on that floor, then they're probably doing a good job in protecting the floors above and below. I think it would be super important. The hard part too is finding penetrations in the floors and ceilings and deck. But you really want to make sure if you are looking at, creating a whole floor for COVID, you want to definitely find all the penetrations in the floors and ceilings, both sides, and get those sealed up as good as you can. And if you have that space under negative pressure, I think you're protecting the folks above and below you very well.
Yeah. Next question. As an interior designer, what recommendations do you have for interior finishes and furniture in a wing like this that might be different than others? That's a question for me. Right now, as we said, we're in early stages, and this webinar is just specifically talking about the unit, the bedroom, and then the building of a wall. We still have yet to identify all of the parts and components and the functions of everything in this unit. But right now, as of late, all facilities, in my opinion, have been using materials, both in their soft goods, their upholsteries, that are wipeable and cleanable and scrubbable, and surfaces that are easy to clean and maintain and sanitize. So we've already been using quite a number of very effective and appropriate finishes in all of the, I want to call it cosmetic finishes of that architectural interior. So right now, offhand, I don't think of anything beyond what we're normally using right now, but that might be the purpose of another webinar if we encounter and really study these type subjects. I'm thinking right now of more of those solid utility. What do we do for laundry? How do we handle those? More of a function part rather than the interior finishes in these units that might not be sufficient enough. But I think for overall, everyone is using something that surfaces that are cleanable and scrubbable. Bob, are you finding that same to be true?
Yeah. And when people ask me, actually, they ask me the question once and then they don't ask me again. But when they ask me the question, what I say is, well, make everything stainless steel.
Oh, what?
And then they
No,
hey,
Bob, no.
It's cleanable, scrubbable.
No. We're still maintaining a home-like appeal to these areas and to these units. So.
Well, and that's why they talk with an interior designer versus an engineer.
All right, next question. Let's see. We have been working with the Army Corps of Engineers on a rapid prototype COVID hospitals, and they are requiring negative air. No, it's not a question, it's just a statement. It's true. What is a good layman's description of using a negative pressure room? So we might have people that are not engineers. Scott, you want to describe negative pressure room in layman's terms?
Sure, it's just keeping the room air pressure negative in relation to other rooms. So your adjacent rooms, your hallway, the air is flowing from the hallway into the patient room or the resident room because that's the negative space. So when it's negative, it means air is flowing into the room versus positive, air is flowing out of the room. So if you have an isolation room, you do not want it to be positively pressurized.
Sure. Perfect. Thank you. Next question. An assisted living is proposing to use their split systems in the resident rooms and run the bathroom exhaust vent continuously to create negative pressure and not recirculate the contaminated air. You mentioned a door closer, which I will pass on to them. Do you have any other comments on this proposal?
I would just say not sure what the objective is, but the amount of airflow to keep the room negative if you want to use it for COVID-19. Really look at that in detail, just to make sure you have enough airflow and you keep it negative.
Bob, anything else you want to add to that?
No, I don't think so.
Okay. All right, next one. It says politics aside. Uh-oh, what kind of question is this? Are there recommendations for using a UV light or a 405 nanometer, I'm guessing, light fixtures to treat entrances and exits to those areas?
I've seen people use them. I don't know. I'm not I'm not an expert on the UV light, so I'm not sure I can comment a whole lot about that. I know it's a technology that's being used more and more, but I'm not sure I can comment too much more than that.
Why don't we save that one? We'll get an answer to that question and respond back in an email format as to what we would recommend, or find someone who could recommend something for that. Use our breadth of our team of experts. Next question. Exceeding concern that we have been addressing resident patient issues, but still missing the issues of care and service staff. Some have spoken of recasing housekeeping and porters as environmental engineers to seriously address cleanup by a risk assessment related to present and possible future materials. And we seem to be terribly concerned about the direct care and missing the hidden service workers' safety and impact of cleaning techniques on transmission and mitigation of the issue of transmission. That's a very long statement. And that goes right to the point of, that's what we're saying. We don't want to lose sight of the health concerns and the safety concerns of the other staff that is cleaning up in these units, and such as soiled utility, soiled linen, etc. We need to keep that in mind, and that's that evolving guideline creation of how do we define that, and what is the best scenario that we can do. I'm not sure there's a question in there, but we know that it's very, very important to keep this in mind of how to keep staff, not just direct care, but supplementary staff in the area, housekeeping, for example, clean.
And I would say
safe.
The housekeeping staff, I mean, everybody in long-term care is utmost importance, and not, you know, you can't, you know, step down and say, okay, this one's the most important, this person's the next one. Along with that are the housekeeping staff. They're really the front lines of keeping everybody in that facility safe.
I would agree.
And by cleaning those rooms and disinfecting those rooms, they are doing as important of a job there as the direct care staff are doing their stuff. So I wholeheartedly agree with that.
That's right. Okay, next question is, how quickly will copies of this presentation slides be available? You know, Lori, I know you're on here from Sage Federation. I think we'll send out an email yet today. Is that too soon, Lori?
No, it just depends on how quickly Zoom can turn around and get us the link to the recording, because I would like to send the PDF of the slides as well as the webinar link out all at once for the recording. And so, but I anticipate that should go out later on today.
Later on today. And then the other part of this question is, could they be available today, and answers to questions, period, follow if necessary? Absolutely, because it might take us a little bit to type up these questions and type out the responses. So we'll do a follow-up email to all attendees and send it out again, all the questions and answers that we can, and any other information that has popped up from now until the time that we send it out. So absolutely. We know that time is of the essence, so we want to get this information in your hands. Okay, next statement. Before I read this, well, I'll read it. What scientific study do you have that promotes a greenhouse or small house environment over other environment? I agree that it makes more sense that those types of environments might work better, primarily because they utilize private rooms, but it is too early to state that they do without empirical backing, and there are too many variables that come into play. I agree with that. We're guessing. That's what I was saying. We're guessing that a small house or a small household model is going to work well. We do not have any scientific study. We don't have any studies on this at all. We're getting information, and we want to compile data and information. That's why it's so important that if you have a community that is, whether it's traditional care or household, we want to hear the feedback. We want to hear positive outcomes. We want to see how you're able to adapt to this new care model, and if it's working better if you're in a household model, and why. We want to compile that data so that we can bring that to every provider in the nation and say, here's what we're hearing from this care model, and here's what we're hearing from this care model. We don't have that information. It's way too soon to see, because all operators are focusing on how to create this unit, how to share the burden of taking on this urgency of creating these COVID-19 units in all of their communities. And so that urgency is there. So the data is going to be coming in much later, and we want to compile it as quickly as possible. Again, we really want to hear positive outcomes so that we can spread the word too on these long-term care facilities and what you're doing and what's working well to help ease the fear of family and residents living in your communities. All right. A few more questions, guys, and then we can wrap it up. It's 10 after the hour. Let's see. Bob, for a temporary room, are you recommending flooring replacement to a seamless flooring with an integrally coved base or not?
That was for a temporary AII room.
Okay.
Oh, so you're talking about a temporary AII room. So is this in for a long-term care facility, or they say?
I'm
I
not
wonder-
sure. In general, I would think that it would not be, you would not need to change it to a seamless flooring with an integral cove base. That integral cove base has everything to do with frequently cleaned, which these rooms would be, but I think a rubber base or the standard base that's used in these rooms would be sufficient. Bob, do you disagree with that?
No, I wouldn't. What I would say is, if you're creating a temporary, negative pressure bedroom, that is different than an airborne isolation room. So if you say, I want to build an airborne isolation room, then we'd be like, well, yeah, then you need that floor in the integral base. If you're just converting a room to negative and, maybe you're doing some innovations or something else in there. But again, somebody's going to be having another drink now, but it depends on your risk assessments and what that says. And if your risk assessment says that, the flooring that you have is okay for this temporary use, then you would probably be okay.
All right. Next question. Our facility sectioned off 4 rooms, a temporary wall across the hallway with a door. Should all bedroom doors be open even though there is a dedicated exhaust system? Good question.
My answer would be, well, what does the mechanical engineer say, and what does your infection preventionist say? Are the only exhausts the exhausts in the toilet rooms in the bedrooms? Is that what the question said?
I think that it's let me scroll down.
That might be what they're inferring, Bob.
Okay.
And most of the time in nursing homes, well, at least in Minnesota, the doors are not closed, and there's maybe a curtain that's there. So doors are generally open anyway. And if you've got a quote unquote COVID unit, and you've got that temporary wall and door, the doors in the bedrooms would not necessarily have to be on closers or shut, because it's that entire unit that would be protected or under that isolation. Would it be better if the doors were opened? Probably. The air would still infiltrate underneath the doors. You probably have at least an inch underneath the door. So you're still going to have air, moving through. But again, that question's best answered by your mechanical engineer and your infection preventionist and their goals and what they need to get done.
Yeah, I think it'd be better, like you say, Bob, to keep the door closed if you can, and then that way your corridor is like your ante room, if you would, and so you've got from less clean or less dirty to more dirty type thing, or infectious type arrangement of the airflow.
Okay, more questions, guys, just email me at that address, jschrader@popearc.com. I'll be happy to find the answers to all the questions and get them back. I want to mention that I am Vice President of Sage Federation, so we do appreciate your time on attending this webinar. And just a reminder before we wrap up too, that we do have yet another Sage webinar tomorrow already, a free webinar. And if you go to our website, sagefederation.org, you can easily register for it. It's on quite a different subject of the winners of the remodel and renovation competition. And it'll be a very positive and happy webinar. So please join us for that. As we wrap up today's webinar, we do want to thank you sincerely for attending our session, and thank you, Scott and Bob, for taking the time out to join with me today to give this very urgent and very necessary presentation. And as I said before, at the conclusion here, you'll be prompted to fill out this survey, and we do want to hear your feedback. On behalf of Sage and behalf of Scott and Bob and myself, thank you so much. We hope to see you again at a future webinar with Sage.